8:30 ആയല്ലോ.
Madam, only 53 participants have joined. Shall we wait for 2-3 minutes?
Hello? Hello, Anna George? Anna George?
Sulekha,
No.
better we start in time. Others will join because it's too early, no?
Yes, ma'am.
Hmm.
Shall we start now, ma'am?
Anna George noted. Anna George.
Dr. Anna George, please unmute yourself. We cannot hear you. You are muted. Please unmute yourself.
Can you hear me now?
Yes, ma'am. So shall
Okay.
we start now?
Yeah. Yeah, sure. I'm ready.
So start now.
Oh,
Let the participants join in between.
sure.
Good morning and good evening, everyone. Today is the second day of International Webinar Series on Challenges of COVID-19 on Nursing Education and Disability Management. On behalf of Government College of Nursing, I welcome each one of you to today's sessions. Ongoing COVID-19 pandemic will have major impact on all aspects of nursing, from students wishing to enter the profession, students already enrolled in nursing, and those that teach them, most assuredly the practicing nurses. It has already shifted the educational landscape. So we have 5 sessions today. The first session is on overcoming hurdles and challenges in nursing education during COVID-19. It's our privilege to have an eminent speaker, Dr. Anna George. She currently serves as family nurse practitioner at Northwell Health System and assistant professor, Molloy College, New York, United States of America. Let me take this opportunity to say that she's a proud alumni, did bachelor's in nursing from here. She obtained her master's in nursing from Molloy College in family nurse practitioner track. She was awarded doctorate in nursing from Molloy College itself. She has been a registered nurse for over 30 years, having experience in medical, surgical, oncology, surgical intensive care unit of various hospitals of New York. From 2006 onwards, she has been practicing as a nurse practitioner. She has many paper presentations, panel discussions, and attendance at conferences to her credit. She also has co-authored an article in medical surgical nursing. Dr. Anna George proudly serves in various nursing organizations and is currently the chair of Indian Nurses Association of New York. Ma'am, kindly take over.
Thank you. Hello, everybody. Good morning, good evening, good night to all the panelists and participants from all the different parts of the world who are joining us today. First of all, thank you for your very kind words. I'm honored and humbled for this great privilege given to me to present today. I am proud to let you all know, as you already heard, that I am an alumni of College of Nursing Kottayam, and I belong to the first batch of College of Nursing Kottayam. All that I am professionally is due to the strong foundation that I received from College of Nursing Kottayam. I am so grateful and so thankful to all the faculty of College of Nursing Kottayam for their dedicated service. You have produced some really strong leaders in the nursing profession, serving all over the world. And I just briefly saw Sister Consolata. She was one of my professors. I am so thankful that she's here today to hear all of us speak. And I'm speaking here with my classmates. I have Lena, she's my classmate. Suleika is my classmate. Gareja is presenting. I'm so thankful that I'm here with all of you today. With that, I'm going to go to my presentation and I am going to share my screen. Bear with me while I do that. I'm sorry, I have to start from the very beginning. I was okay. So my topic, as you see, is overcoming hurdles and challenges in nursing education during COVID-19. So it was already said, I teach in the Graduate Family Nurse Practitioner Program at Malloy College, which is a blended education learning system that we use. Most of the lectures are face-to-face, even though we use online, but not as much. Have with direct face-to-face, we have direct interaction with the students, and we have opportunities for the students to practice hands-on experience. And faculty is always available for the students. Lectures and labs are designed to fit the student schedule. Most of the graduate students are employed full-time. So graduate education is usually part-time for most of these students so as to fit their schedules. Now, we had an unexpected visitor, as you all know. That was the COVID-19 made all our lives so miserable. So in March 2020, deeply concerned both by the alarming level of spread and severity and by the alarming level of inaction, WHO made an assessment that COVID-19 was declared as a pandemic. Most colleges in US closed with the plan to completely go online. All faculty were given accounts and training in Zoom. We did have some experience, but not to the extent that we were going to use it at. Faculty were told to use all the available resources in Canvas, which is our learning management system. We used Shadow Health, which I'm going to show both. Shadow Health is a digital clinical experience that we have been using in Malloy College, but not to that extent that we needed it after the COVID. So I'll talk a little about that also. So overcoming some of the hurdles. The first hurdle was the clinicals stopped abruptly for all students, and finding alternate means of clinical for graduating students so that they can complete their clinicals became a dire emergency so that we can allow these students to graduate on time. Abruptly changing to an online education for classes was very hard, not just for the students, but it was for the faculty also, because nursing is a profession where we use a lot of hands-on. There's a lot of demonstration and return demonstration. And the biggest challenge was the spring semester. We have semester system, as you already know. The spring semester ends in May, and the COVID came in March. So we had like about 2.5 months to complete the semester. Moreover, more importantly, to make sure that these students graduate on time with all the necessary education that they need for their graduation. So first, faculty had to educate themselves and become experts in alternate means of education to enable the students, to teach the students and to make sure that they graduate on time. So I'm going to be talking about some of the learning system that we used. One is Canvas. I'm going to show you Canvas. That's the learning management system. And I know that every schools and colleges have their own management system. We use Canvas. That is the learning management system of Molloy. Then we have Shadow Health, digital clinical experience. I'm sure few of you might be familiar with it, but I'll walk you through how we do it. Also, Zoom was great help. I used Zoom for synchronous lectures, for demonstration and return demonstration, and I'm going to take you to that also. And also Voiceover PowerPoint, and I'm sure that you use that also in your colleges. So this is the online Canvas learning management system at Molloy College. This is our face page of my course that I taught in the summer. I actually taught 3 courses during this summer, which is each one has a box and each one has an embedded system in it. And I'll take you through in my next slide. So the next slide, this is one of my Canvas course, 582. We give numbers to our courses. It is a family nurse practitioner program. And this is course primarily deals with primary care, medical, surgical, primary care. And if you look at the left, you have all these tabs. If I have to announce any of my, say I have to say something to the students, I just have to go to announcement and put it there, because today we had a big outage. Electricity was cut down and I could just write here because of the no electricity, Molloy College is closed today, so I don't have to call anybody. Zoom is embedded right in here, so I do my synchronous lectures through that Zoom. In the modules is their weekly schedule. I put all my PowerPoints and whatever is needed into the synchronous lecture. The syllabus is when they click on that tab, they get the syllabus, which is right from the beginning of the semester. The grade book is embedded right in here. Once the quizzes are given and the exams are given to these students, I say patient, to these students, they go directly into the grade book. So we don't have to do anything with the grade book. It's embedded in there. I'm going to show you a lockdown browser. This is how we give our exams. And the main purpose of giving the exams when we give it online, the lockdown browser makes sure that they are not able to cheat. So I'll take you through that also. Panopto is a learning system where you can record your lecture using a PowerPoint. I'm sure many of you are familiar with Panopto, but some of you might not have been that familiar. So in Panopto, you can show your PowerPoints and record your lectures. So I'm going to play this video. I will not be playing the whole video, just to have an idea of what Panopto is. So I'm hoping that it plays and you can hear it.
Panopto is a video platform that helps your team communicate, present, and learn more effectively. With Panopto, you get a secure portal where you can publish your videos and easily share them across your organization. One of Panopto's unique features is the ability to search inside your videos. For every video you upload, Panopto indexes the presenter's speech and any text that appears on screen. As a result, your employees can find and fast forward to any words spoken or shown in any video. It makes video perfect for just-in-time learning, and it means you never have to worry about tagging your content. Panopto also supports interactive video quizzing. This enables instructors to create quizzes, embed them directly inside videos, and test comprehension, all without the need to use separate e-learning authoring tools. Uploading existing videos and creating new ones with Panopto is incredibly easy. For your existing video files, simply drag and drop them into your video portal. Panopto will convert the videos for optimal playback on any device. For creating new videos, online presentations, and events, Panopto includes an integrated live streaming and recording tool that's easy enough for anyone to use. Simply launch the app, click record, and Panopto will capture your video, the content of your screen, and any additional video sources that Panopto is a video.
Sorry, I'm going to take you to the next slide. One second. Okay, so that was briefly about Panopto. We use PowerPoint and Panopto to record a video and your voice so they can see it at any time. All they have to do is click on this. The next screen that here it is exam via lockdown browser using Webcam. When we give a quiz, we put them on a lockdown browser, which locks all the browsers of the computer. That means when they're taking the exam, they cannot access any other browsers in the computer. They can't use Google or any other website, go searching for the answers. So this is actually important to make sure that they are not cheating during the exams. You know, it can happen. So we try to do that. The next screen that we want to make sure when they're taking the exams is, along with lockdown browser, we use what is called the webcam. Here, before they sit for the quizzes, they have to make sure that the camera is on. We tell them that in the while the camera is on, the student is supposed to show their photo ID to make sure it is the student taking the exam. They have to not only show their face throughout the quiz or the exam, before the exam starts, they are told to take a video of their surroundings, which makes sure that they don't have any books or any other iPad. You know, these students have more than one device. It's not just their computer. So if you lock down that browser, there are other devices. They have their phone, they have the iPad, they might have another computer. So we want to make sure that they don't have any other devices on the table. So this environmental check helps us to do that. Make sure that we tell them that they cannot have any books on the table, they cannot have any other devices while taking an exam. And if for some reason they do have all those things, and if they are looking at something, this webcam will highlight it for us and mark it for us. So we don't have to watch 50 or 60 videos of students taking the exams. We just have to watch that one or two that are highlighted for you with marking. So when you go there, you figure out what the student was doing and maybe have a direct conversation with the student to see what happened during the exam. So that's what's lockdown browser and webcam. Now, I did tell you that I'll talk to you about shadow health. You know, we are nurses. Hands-on experience is what is so helpful for us to prepare our students. And during COVID-19, most of the hospitals and clinics were closed down for the students and they could not go to the clinicals. So shadow health digital clinical experience allows the student to examine this patient online. It is an avatar, but this avatar's name is Tina Jones. She is very familiar to most colleges here. So the student is able to examine this patient virtually. And this is also a long video. I'm not going to show you the whole thing, but I just want you to have an understanding on how the student can ask question. The student can type the question in this bar, or she can use the mic here to talk to the patient. Hi, Tina, how are you today? What made you come to the clinic? And Tina will answer that question for her. After she has obtained the history of the chief complaint from the patient, she will tell Tina Jones, here I am going to examine you. And I'm just going to show you how you can examine Tina Jones, just that part of the video. So I'm going to play that video. And like I said, I will not be playing the whole video. Oh, sorry. Is it playing? I see that it's not playing. Can you hear me?
Yes, ma'am.
Good day, everyone. My name is Nancy, and I am inviting everybody to join me as I perform a physical assessment. Okay, and going down to the lower chest.
She's doing percussions.
Okay, moving to the posterior chest, I am going to auscultate the lungs, starting at the left upper quadrant. Okay, and the right upper quadrant.
That's
I'm
a
going to the
stethoscope.
mid-level and to the base of the lungs, which is the lower lobe. There you go. And also I'm going to palpate for any tactile premises, starting on the upper back. I'm going to ask the patient to say 99 as well, to the middle and to the lower back. Okay, to finish with the respiratory.
So this way you can see your student examining the patient, and you want to make sure that she's using the right technique and she has the stethoscope at the right spot and she's using the hands the right way, and you can give her constructive criticism so the next time she can correct her mistakes and learn that way. Now I'm going to the next slide. This is Zoom, how you can use a clinical scenario now that they cannot go to the hospital and we are all home. What I do here is I ask the student to have a partner in their house. It could be the husband or children, and they can examine their partner, and we can give them instructions on what was done right, and we can correct them if there was anything done wrong. So in this, you're going to see my student. Her name is Monica. She's examining a patient, and I just, with her permission, made a clip of video to show you how we use Zoom for a live clinical experience and examine the patient. So hi, Monica. How are you doing today?
Good. How are you, Dr. George?
I'm good, thank you. So Monica, you're going to examine this patient that is in your clinic, and he's going to tell you his complaints, and you see what his complaints are, and then you can examine the patient, okay?
Okay.
Okay, go ahead. I'm ready. Are you ready?
I'm ready.
Wonderful. Go ahead.
Okay, so I would walk in the room. My name is Monica. I'm going to be your nurse practitioner today. I would wash my hands. Can you tell me your name and your date of birth?
My name is John Smith, and my date of birth is April 6, 1994.
Okay. And can you tell me what brings you here today?
Recently, I've had shortness of breath. I've had some trouble breathing. I use an inhaler, but at night my symptoms seem to get a little worse, and I have a little trouble breathing and more coughing.
More at night, right?
At night, yes.
Okay, good. All right, so I'm going to do a focus assessment. I'm going to do heart and lungs, but I'm going to start with lungs first.
Okay.
So first I start with inspection. I'm looking at the patient. I'm seeing if he's in any visible distress right now, which he isn't. I'm checking the fingers out, seeing if there's any clubbing, if he has any pectus incavatum, and that would restrict his breathing. I'm then going to ask the patient to turn to his side. So I'm inspecting the anterior, and then I'm going to have him turn his back to me. Please, John, thank you. And I'm inspecting the transverse, and the AP is shorter than the transverse, which is normal. It's 1 to 2. So I'm going to start off with palpation. And I'm going to just palpate down the back and ask him if he feels any tenderness. Do you feel any tenderness?
I don't feel any tenderness.
I guess you get the idea of how you can look at how she's examining the patient, and you
then
can.
I'm going to check for tactile fremitus. So I'm going to put the base of my hands against his back, and I'm going to ask him to repeat the phrase,
So by looking at that video, I can tell her, no, Monica, that's not the way you do it. Oh, yes, you did the right way. Go ahead. You've been doing wonderful. And you, even our final exams were given this way during the COVID season because there was no other way. So we told them to find a partner, and in the house, we gave them a scenario. A 56-year-old male comes with asthma. You're going to examine, give me the line of treatment, and what are the medications you would order for this patient. So that was actually useful to see how they do that. We go to the next screen, which is voice over PowerPoint, which is asynchronous learning. It was not really very popular with my students because they liked Panopto better. They said that voice over PowerPoints, you had to always sit in front of the computer while your PowerPoint was playing and to hear the voice of the professor. So they were saying that for them, Panopto was easier because most of these students, they say that they listen to you in the car, in their workplace, when they're cooking and cleaning, they always are listening to the Panopto, which was possibly not possible with the voiceover. So they used both, where we have been using interchangeably voiceover PowerPoint and Panopto. I think I'm coming to the end of my slides just to give you some of the advantages of online education. Yes, there are some advantages. You know, the convenience, you don't have to get dressed, you don't have to travel. You have your flexibility, the time and pace is yours. You don't have to sit down through class lectures if they're boring. You know, you want to run away, but you can't. You have the ability to view and review the materials and videos as needed. Low cost, you're not looking for parking, you're not looking for food, you're in your own house, you can eat away all you want. It is less stressful because of time and for finding parking. You don't have to deal with other students who are disrupting the classroom, and you don't have to wait for other students who have a slower pace than you. So you can go at your own pace, slower or faster, whichever your pace is. And you don't have to work in teams. I don't think that is correct, because now with online education, you have a lot of discussions that you have to participate in. With that, I go to disadvantages of online education. If you are a student who procrastinate on doing things, you will never get it done, because you'll say, oh, I'll do it tomorrow. It is hard. It is harder to understand the content when not face to face with an instructor. You know, we in our college is face to face. It is so easy to go to your professor and tell them right away what you didn't understand. Can you explain it again? Possibly not as easy in an online education. And also, online education needs self-discipline for reading and learning. You're doing it on your own. You don't feel like anybody is watching you, but they are. So you have to be very disciplined to get through your program. Sometimes it is likely that you may misunderstand directions and you don't have the professor right there to ask you. It is more stressful trying to reach your instructor. Sometimes they are not answering. They might take their sweet time, which hopefully not. But also it is hard for students who have problems with technical issues, right? With IT, who are not very good at all those, it becomes hard for them. Then the most important other is computer related distraction. You know, this generation is all into computers, Facebook, Twitter, all the other 100 accounts that they have. So while you are online, you feel like, okay, let me search the web. Maybe I should shop online. Maybe I should go on Amazon. So there's so many distractions online. So that is another disadvantage. And you require increased use of email. I keep telling my students, always read your emails. Most of the communication comes through email. So if you don't have the habit of doing it, you have to build up that habit of reading and keeping up to date with your emails and all the other communication that is coming to you. The last one is that social interaction, making friends. That's all gone with online. You're sitting alone with your computer in your house. So that is actually very hard to make friends, to have that happy occasion with your friends is all gone. I think those are some of the disadvantages of online education. I know that I'm probably running out of time. So, or I think I'm on time. So I think I am done. These are my references. I am going to stop sharing my screen. I don't know when the questions come. Is it after this session or is it after all the sessions? You can take it over. Thank you very much for listening patiently to me. Thank you all.
Okay, thank you, Dr. Anna George. So that was an eloquent presentation on different modalities of online education, and some of the technologies are new to us. And now we will, questions will be at the end of the session, we can encourage. Okay,
Sure.
so we can move on to the sessions in time. Okay, please be with us. Okay,
Sure. I will. Thank you very much.
yeah, thank you.
Next, we have Mrs. Lena Alapat to deliver on COVID-19 management challenges in neonatal intensive care units. Mrs. Lena Alapat secured first rank in Bachelor of Science in Nursing from Government College of Nursing, Mahatma Gandhi University. She obtained Masters of Science in Nursing and has Pediatric Nurse Practitioner certification from Pediatric Nursing Certification Board, UK. She is a neonatal nurse practitioner in the Level 4 Neonatal ICU at Children's Hospital at Montreal, where she is responsible for the management of critical neonates and coordination of patient care plans with attending neonatologists. Mrs. Lena Alapat is also involved in the education and training of residents, fellows, and nurse practitioner students of the neonatology division. She also participates with the research activities of this unit. She is also active in various community organizations and professional societies such as New York State Nurses Association, National Association of Pediatric Nurses, Nurse Practitioners, and Sigma Theta Tau. She is the Education Program Chair of National Association of Indian Nurse Practitioners. Over to you, ma'am.
Thank you very much. So I'm Lena Alapat. I am very happy to tell you that I am an alma mater of College of Nursing Kottayam, and I am so excited to be in the presence of my friends and all the students who are going to my school that I call as my mother house. And especially, I know my teacher, Sister Consoletta, is also in this panel, and she is like one of our first teachers when we started nursing school, and I'm so excited to be with her. So I am talking about the management of newborns affected with COVID exposure. I am living in New York, and here we had a very widespread corona infection and a big major pandemic all over the New York State, which was in the beginning of this epidemic in March, April, May time. And I work in a unit that takes care of very sick neonates and deal with delivery room where a lot of COVID infected mothers are coming in to deliver. Many of them deliver prematurely. Many of them are at regular time. And I am talking about the management of newborns and their exposure to COVID and some common recommendations. I'm trying to share my screen. Please bear with me. I have to go to the beginning. Can you see? Okay. All right. So we are dealing with the challenges in the management of COVID-exposed newborns. So transmission of the COVID infection to newborns is the first one. So when we think about newborns coming from a COVID-infected mother, the vertical or in utero transmission of this COVID-19 virus to the newborns are very unlikely And that's what the research is showing. And all newborns that were born in our institution who were born to COVID positive mothers, they were all tested at multiple times and they were all negative. Amniotic fluids from moms, vaginal fluids, placenta, the cord blood, meconium samples for the newborns, they were all tested negative as well. And the theory right now is the postnatal transmission via contact and droplets is the main reason. And it's from the mother or the caregivers who are taking care of the baby. They are the ones who are giving it to the babies. Compared to the adults, the newborns are found out to be very less susceptible to COVID virus because they have very immature kind of immune system. And the main ACE2 inhibitors of the lower respiratory tract, that's where the virus get attached and it makes a very severe pneumonia in adults. But when you consider newborns, they don't have these receptors. They're not really fully developed, and so they don't get a real full-blown disease. So newborns are really, that's why people are saying they don't get a bad disease. Fetal and neonatal implications, complications of note. Half of the mothers with COVID infection are seemingly going into preterm labor, especially those with the respiratory type of the infection with unknown reasons because they have more severe type of illness. And we see that these mothers come in and they are already ruptured membranes and they're going into preterm labor, they're getting sick. And so we will have some preterm infant born to her and coming into the neonatal ICU. Even though the mothers are infected with COVID, the fetal development and growth did not seem to be affected. Like the babies are normal size. They are really not IUGR or anything. But when the mothers are really ill, we see that the babies are in distress, like fetal distress, PPROM with thrombocytopenia of the newborn, shock, stillbirths, babies with multi-organ system failure. Sometimes the newborns cannot, they get very ill with their mothers. And especially those moms who are in the ARDS, like acute respiratory distress syndrome of the adults, they are really ill. Of all pediatric cases of COVID infection in the United States, about 15% of the hospitalized were infants. But that does not mean that they are newborns, but these are infants meaning less than 1 year of age. And they're usually over 1 month of age. These infants had lab confirmed positive status and with mild dyspnea, fever, rhinorrhea, lethargy, coughing, and feeding issues, and mostly a mild disease. That's the common scenario that we are seeing. And since they're newborns, they are admitted and they're cared for in the hospital. Now, when we consider the pregnant mom and the COVID positive status and the delivery room management, during the outbreak season, all the mothers and their partners are required to have screening tests prior to hospitalization. So we ask for this. We ask that the mother and the father or the partner of the mother, they both be tested and have their results available to come in. But the reality is a different situation. Confirmed positive mothers or partners are placed on droplet and contact precautions in negative pressure rooms. But many were asymptomatic while positive in preterm labor, many cases. This request for their testing, it's got complicated because many results were pending. Even though they will tell you that they had done the test, they don't have results. The results were coming later and later, as you all know. So we did not have any results of the mom or the father of the baby. And many of the moms were symptomatic, like they have fever, they have shortness of breath, and they were still tested negative. And we still had to consider these are mothers who are symptomatic for possible COVID infection. So we considered them positive. And all the mothers who were considered, some of the mothers refused testing because it's like a social stigma. They don't want to know if they have this disease and they will not do it. And they just refuse and they stand firm. So all of these categories of people, we had to consider them positive, and the mothers and their children had to be isolated while they were hospitalized. Those who attended deliveries, we were required to be in full personal protective equipment due to the fact that aerosolizing procedures are necessary, like suction of the neonate, and we may have to intubate the baby. If the babies are very premature, they need intubation, and these are all aerosol producing procedures, and people need to be protected. And so we had to wear eye goggles and all the PPE like it's instructed. Delayed cord clamping is part of the delivery, which is still not canceled. It is still being done for stable infants. If the baby is stable, we are doing it. It's not recommended to stop by CDC or WHO, so we are still able to do that. Neonatal team is actually asked to be present for all newborns at birth for resuscitation and evaluation if needed. Newborn care. So the newborns are two types: those who are over 35 weeks of gestation and who are stable, like not needing any resuscitation or any extra care. They are sent to the well baby nursery with isolation precautions, because they're going to the well baby nursery. There is two nurseries now. One is for COVID nursery and one is for the healthy babies. Of course, the healthy babies are kept separate from all with COVID exposure or possible COVID or positive. Premature infants and those who are born needing resuscitation, who are sick, they're sent to the neonatal ICU with the isolation precautions and negative pressure rooms and special protection for the staff who are taking care of them. Those sick infants requiring NICU care with technology dependence, and they needed ventilators, they needed CPAP or all kinds of mechanical assistance. Most of these kids, even though they all were COVID negative, none of the babies are actually COVID positive, but some of them turned positive in 2 weeks, which is from exposure to the family, to the community, and the mother herself probably was not using, protective measures properly. Many preterm newborns were admitted to our NICU. None of them were positive. One of the main thing is feeding of the newborns. And that's one of the main concerns. Droplet transmission to the newborn is possible with contact at feeding. The risk of the transmission is through breast milk. It is really unclear. We are not really proven that the breastfeeding or breast milk has caused the transmission of the virus. If the mother's very ill, definitely the babies are separated and they may not be pumping, they're ill and they are not healthy enough to do anything. They themselves need respiratory support and stuff. They're mostly formula fed and they are cared for by other people. Sometimes we even discharge them to a healthy family member. We did test several samples of breast milk. They were tested negative for viruses. But there are some samples which identified some virus, but we really are not sure if this is capable of transmitting the illness to the baby. In a WHO study of 46 samples of breast milk, 43 were negative and 3 were positive for virus. The general consensus is to encourage breastfeeding for maternal and infant benefits. The infant may be receiving passive antibody protection for the virus from the breast milk, and ideally a healthy caregiver, hoping that there is a family member who's not infected, can feed expressed breast milk to the infant, but it's not an ideal scenario for all the mothers. They may not have somebody to feed the baby or take care of the baby. The father of the baby may be sick, or there may not be a father of the baby available or in the picture. So if there is no caregivers available, direct breastfeeding is now allowed with precautions. So we are asking the mother to wear a mask, perform hand hygiene and breast hygiene using soap and water, and disinfect shared surfaces. And we are asking the mother to breastfeed. and it's been done right now. The mother and the baby is rooming in with precautions, and that's actually is in practice now. So this isolation precautions and rooming in for the mom and baby. So mom and baby are not separated, but may room in since the risk of transmission to the infant is low per data. The data showing infants who are separated, kept in a separate area like an isolation nursery and cared for, and infants who are allowed to stay in the mother's room using the protection precautions, they all have the same risk. So it is not really acts to separate babies from their mothers. It is generally the best practice for every baby and their mother to be together because it's so much better for the bonding and all of that, good things for the baby. Mothers should wear face masks and practice hand hygiene and breast hygiene with sanitation of shared surfaces. And babies are placed in a room about over 6 feet from the baby, from the mother who is infected. And make sure that the mother and baby are not together, but a little spaced apart. Or we could take, we can available an incubator for the baby. So the baby is enclosed, it's not in the environment. And continue precautions with positive, symptomatic, and when they are discharged. So we will have to continue precautions like this physical distancing and this hygiene practices for all positive symptomatic mothers until 72 hours after the complete resolution of all symptoms, with 10 days from the first appearance of symptoms. So if you start fever one day, you have to wait for all the symptoms to go away and then 3 more days, and then the mother can kind of get away with all these precautions. If it's a asymptomatic positive mom, then we can say the mother can get over the symptoms. So asymptomatic positive mothers needs to continue the precautions for 10 days since their positive test results. So we are hoping that she is out of all the viruses by that time period. Care of newborns testing and follow-up. So all newborns with COVID positive mothers are tested for COVID by reverse transcription polymerase chain reaction tests, or RT-PCR, at 24 hours of life. And we repeat a test at 48 to 72 hours of age, another repeat, with nasopharyngeal swabs is most common used type of testing. So the RT-PCR testing is done for all newborns born with suspected COVID or exposed to COVID or positive COVID moms at 24 hours of life. And we try to repeat it 48 to 72 hours, whichever is available. These infants can be discharged home and given follow-up appointment with the pediatrician at 2 days post-discharge. And many community pediatricians are right now doing tele visits at this time because of COVID. Yeah, and the next thing is pediatric infectious disease appointments at 14 days of age is also recommended. The complete test at that time to identify for transmission and the need for continued isolation and prevention of community spread. But at this time period where we really don't have so much tests available, this 14-day test is actually going away because we don't have as much testing supply. Next concern is parental education. Newborns who meet criteria for discharge home with their parents. Convey the test results if available to the parents. Because at my institution, all the newborn tests are done as rapid and the results are available in like 4 hours after we send the test. All the newborns are with the rapid testing protocol. We need to teach the parents one important thing of this hygienic precautions. Breast pumping, many mothers opt not to keep the baby with her, but have a healthy caregiver feed the baby with breast pump, and express breast milk is fed to the babies until they are resolved with their infection. And so breast pumping also needs to be a lot of hygienic practices. They need to have, since the mother's handling the tubes and the pump, it needs to be completely sanitized. And most likely we will recommend a healthy caregiver, whoever is the helper for the mom, should hygienically clean it. All the plastic bottles that they collect the milk, also the outside of the milk bottles has to be cleaned with wipes, like bleach wipes if available, and left on a room outside for like a few hours before you put it in the refrigerator. So we are hoping the viruses, if any, on the outside may die. Even though the mother is washing and everything, we still are concerned about those kind of. So breast pumping has a lot of real hygienic techniques that the mother needs to follow. And breastfeeding also, we are asking the mother to be keeping lots of hygienic techniques, and the mother has to be wearing a mask all the time. And also remdesivir, we consider this safe for breastfeeding. And this has been studied in Ebola outbreak in Africa in 14, and it was seemed safe. So many mothers who have illnesses that are severe are taking remdesivir, and they are okay to breastfeed. It is safe for breastfeeding. And post-discharge follow-up visits and discontinuation of all the isolation and safety techniques also has to be discussed with the mom and dad. So I'm talking about the summary and recommendations. So COVID infection in pregnant mothers is presenting a challenge to caregivers and families just alike. Infants born to non-COVID mothers should be isolated from healthy newborns, and they should be cared according to infection control recommendations. Breastfeeding and cohabiting of the mother and newborn are now allowed for non-COVID-19 mothers. All precautions to avoid droplet transmission to the infant must be instituted from the mother and as well as the caregivers, because you don't know who is positive at this point. Because the caregivers also has to use protection, hand hygiene, and a mask while caring for an infant. Need for follow-up appointments and test results of the newborn should be communicated to the parents. And parental education is like a very important part. And here are some references that I have used. And so hopefully I am hoping that I was able to tell you some of my experiences, because I live in this New York City where COVID has been really rampant. And we've been going through a lot of issues. So thank you all. And I hope everybody's staying safe and healthy. Good night. And stop sharing.
Madam has given us a detailed address regarding the challenges of COVID and neonatal ICU, especially the difficulties in delivery room, management of newborns, focusing on feeding, isolation precautions, testing and follow-up, and the most important aspect, the parental education. So we have one question in chat box. That is Sachuke asking, is there any difference in symptoms of coronavirus disease for pregnant women? Who is at greater risk, mother or baby?
Babies are not at greater risk at all. Pregnant mothers and normal women have the same sort of risk for contracting the disease. And some people do get severe disease, and we really can't say who gets it. People are considering a few of the comorbidities like diabetes, high blood pressure, sort of those are like more risk factors for any women. It's like common, any women gets the illness, and you being pregnant, you're not really at increased risk. And the complications of COVID is mostly in mothers and not in newborns. Mostly all the newborns are okay, unless they were born preterm, they have the prematurity, and there are a lot of complications associated with that. Other than that, the babies were not COVID positive. I had like so many mothers and so many babies born in our hospital, which is like a city, very busy hospital, with none of the babies were positive.
Thank you, ma'am, for the interesting and enthusiastic session. It was really useful. And all of the rest of the queries will be addressed in the discussion session. I request you to be online till the end of the sessions.
Sure, sure.
Thank you, madam. Thank you.
Okay, now we will move on to the third session in today's presentation, and that will be dealt by Dr. Girija Kottayam. And she will be speaking on emerging remote teaching in nursing, a paradigm shift. And Mrs. Girija is now the head of Department of Maternal and Child Health, Sultan Qaboos University, Muscat. Coming to her educational background, she is a graduate of this college and post-graduation from Government College of Nursing, Trivandrum, and obtained PhD from Mahatma Gandhi University, Kottayam. The areas of interest include nursing research, obstetrics and gynecology, that is her specialty, and nursing educational psychology, nursing administration, and health promotion and education. And she has over 30 years of experience, and among which more than 20 years in collegiate experience. And she has many national and international publications in industry journals. The project currently undertaken by her is Remote Teaching Competency and Challenges, Exclusive Breastfeeding Practices and Evidence-Based Practice Competency of Undergraduate Students. So I think Girija can speak on to these topics. Now over to you, Ms. Girija. Can you all hear me? Very good morning to all. Hope you can hear me.
Yeah.
Okay. First of all, let me thank the chair and the organizing committee, and I am very glad to see my compassionate and role model teacher, Sister Consolata. Thank you, sister. And I am really privileged to see you in the sessions, and moreover, my colleagues are with me. It's a real privilege to share our ideas and all. Okay, let us go to my topics. Emergency remote teaching. It is now like a COVID teaching in the educational system. This is the most common terminology we used. And COVID-19 pandemic has really jeopardized all sectors of life, and it has taken millions of lives across the globe. So this emergency remote teaching was the only forced choice for the educators with the given public policy of lockdown and social distancing. And it is a paradigm shift in nursing education to continue the education and to bridge the gap in connectivity of the teacher and the students. So let us see what is this emergency remote teaching by definition, and what are their specific criteria, what challenges it brought out, and what strategies we took it to overcome these challenges and all. So this emergency remote teaching by definition, Coates et al., she defined it as a temporary shift to instructional delivery to an alternate mode of 100% online remote teaching due to crisis circumstances, and it is expected to return back to the normalcy when the crisis is over. So that is the definition we also adopted in our setup. Let's go with the next slide. So what this temporary can I have my other slide? Sorry, I can get the next slide. Can I share or you will share? Okay, so emergency remote teaching is not the same as the usual online teaching because of its specific nature. It is just activated during the crisis, and it is a temporary solution to continue the learning, and it is risked with limited resources which you all were faced, and it is compromised with the faculty competency, especially with the technology, as well as we were not able to get the IT technicians on the spot support also. And it is the only forced choice for the students. Even with normal online courses, it is a student's choice. Now it is a forced choice. and there is no pre-preparation, so it is not appropriately designed or planned, and it has got many shortcomings. Then, and it is explicitly delivered in an online mode and in a remote learning. So these are the specific things which we come across with emergency remote teaching, and then we faced many challenges because of this one. So the COVID-19 forced us to adopt the ERT, and then it has produced challenges in all sectors, not only in institution, faculty and students. The challenges were there in the society as well as in the families. But being educators, let's focus on the few challenges what the institution has to produce ERT policies to implement the ERT strategies, and there are not many institutions with a very good learning management system. We do have a learning management system, but then not everybody is very well oriented with the learning management systems. Like we have a Moodle system, but then most of the university does not have a strong learning management system to deal with the remote teaching online, complete online method. That was a big challenge in most universities and higher education centers, and even any educations. Then using the common public platforms and the personal online modes, there were a security issue to both for institution, for the personals also. That's another challenges. Then the faculty is the one who core person who was struggled to implement this ERT strategy, because she or he has to design the whole courses, objectives, and how we can achieve the objectives, and what learning strategies teaching learning strategies can be utilized in this mode, and how we can grade and evaluate students. Then one of the other main main challenge the teachers felt was not all teachers are technically competent. I can say the youngsters who are tech savvy were the most people who are privileged rather than the older generation like us. But we have uplifted, we have studied, we have self-developed, and we used many strategies like peer teaching, reverse mentoring, many things. That was a opportunity for the old generation to get updated, though it was a challenge. Then the academic integrity is the most concerned aspect of the faculty there. Though we make many precautions, and it's an area still in a gray part to maintain that academic integrity in this online. But there are strategies. Let us go with the other things. Then the students, poor students, we cannot blame the students for some of the times, because the connectivity and equity to their part is the most challenging area. And now we know that education in all higher education is student-centered. The students' motivation is important for keeping them engaged and empowered. Is the logo for higher education for student-centered. That lack of motivation also we have as a challenges in this time. And the time management for the students, there in my place there is a cultural and socio-cultural impact also. It's not like the other part of the world. We have a students always complains that they have family constraints and things like that. So the time management was another thing. And then that their technical issue. Not every student has got their own laptops or a big facility. They have to share with the family members, and the parents has to buy for new one, and it is not all the shops are locked down. There were many challenges for the students too. So with these challenges, what strategies we made it in our university, we will discuss. Before that, what are the criteria and factors we need to consider to have an easy implementation of ERT. These are the focuses area we need to look into it. What strategies our university did it also, we will discuss it. Next is the basic. Okay. So the 4 essential area we need to consider for an easy transition of the ERT implementation. what system preparation, we have to make our system preparation for ERT and the learning management system updating, and identify the needs of the students at different levels and at different courses. Then reassure the students, because we need to keep sending the messages, WhatsApp, in whichever way, and make sure that they got the messages, what strategy, what implementation, how are we going to make the objectives melt, and they don't need to get worried. We will meet the things and they can get their grades and they can go with their graduation. So please reassure the students. That's another one. And use the simple ERT measures, like what they are oriented, what we have it. Though we have very high and virtual type of modes, but which are not feasible for the students or to the institution. So what we are basically saying is, for easy implementation or quick implementation, use simple approach to ERT if possible. And if the facilities are allowed and the people are students and the teachers and the institutions are oriented and with the facilities, you can go with the higher status. An ad hoc committee has to be formulated, and we in our university, we had an ad hoc committee and we made an ERT policies also. So the next thing is, we need to consider 4 area being faculty to reduce the confusion among the faculty. Faculty should know, can you share the next slide? Faculty should know what is the expectation of the institution. What is the expectation our institution, the current institution is having, and be aware of the resources provided by the institution. In our institution, we had a learning management system of Moodle, and the ERT policy recommend to use the Moodle as a platform to teach. But we had challenges, so we had to switch to the all other public public platforms also. So be aware of what is the institutional resources available and what the policy says, and identify the contact people for guidance. For sure, we have a communication strategy. If I had a problem, to whom I have to communicate and how to tackle these things. Then create a plan and ask for feedback and approval also. Suppose I am using these strategies, and whether then I need to have approval and consent from my immediate supervisor in order to keep the integrity of the institution, security of the institution. So all these things are essential to consider easy implementation. Next slide, please. So what are the 4 areas or the key components we need to consider for easy implementation of the ERT? So these are the pillars of remote teaching. So let's see what is the choice of online teaching strategy. This depends on what resources we have in the institution, what resources teacher and the student is oriented, and what training opportunity and new or modification is available for the teacher and the students to use it. And the pedagogical approach in ERT. Pedagogical approach, there are many pedagogical approaches. What we recommended and used is collaborative, constructive method and community of interest. Inquiry interest model we used for ERT model. And then faculty preparedness is very, very important, which I already mentioned, that faculty is the key person and the task person, task group to transfer the correct knowledge to the student, and they are the one who use the technology in an appropriate way. So the faculty preparedness is one of the key component. The learners' expectation and motivation is another factor. So keep motivating, make them engaged, and reassure them what we are supposed to expect from them, and please challenge them with the way we wanted to give them get the responses. So that these are the components which we consider to have an effective implementation of ERT. So what are the strategies we developed and we used in our SQ University? Next slide, please. So this is a common knowledge for everyone, and this I am not going to explain there, because we all know that there are synchronous and asynchronous methods depending on the available platform and the resources available for the student and teacher, and the orientation and technical competencies each teacher can choose, and with the expectation and permission of the institutions. So we can go for virtual chatting, virtual presentation, virtual presentations, where virtual group discussion, breakout rooms, and we used both a mixed method of synchronous and asynchronous depending on the topics, depending on the class levels and the area of teaching. Next slide, please. Okay. So these are the teaching strategies we used in Sultan Qaboos University College of Nursing. We already developed an ERT policy. It is being communicated to all faculties, and then the relevant information is given to the students by email, and we already made sure that each student got the information of what ERT strategy and when and how and all sort of things. Then we had the Moodle pages. Moodle page we used. I will show you what are the available option for Moodles, and then the same like Zoom, we can use the big blue button in the Moodle page. We can go as live and talk to them, and they can also see. We all can have the same like Zoom, and we can record. They can replay, and then they can place their doubts as chats. We can share the screen, we can share the whiteboard for explanations. There are many options in the big blue button. This is the one we used it. And in addition to this big blue button, the basic modes of discussion form, chat, quizzes, videos, MCQ categorization and shuffling. This MCQ categorization and shuffling is the one we used basically for our final exam. By the way, I wanted to tell you, not like Anna's college, we were not able to conduct any clinical exams in our institution, because our management system, learning management system did not allow this type of things so far. So we are trying, in this semester, the university academic council is thinking about buying this high virtual media and the models for our clinical things. This was the strategy that we switched on to the clinical written exams for clinical scenario discussion, scenario questioning for the clinical aspects. We did not have any clinical exams at the end, but rather we had a clinical discussions and a clinical video. I myself made a YouTube for my students with my own limited knowledge and technology, which what I did is, with the lockdown and social distancing, I have no other help. So what I did, I just used what is available in my house and in my office. So I just made a YouTube for my students to demonstrate abdominal examination and non-stress test. So this is how we bridge the gap to teach the clinical aspect. Faculty, most of our faculties are youngsters. They are very technically updated and they are very enthusiastic. What I actually update from myself themselves also. That's reverse mentoring was done. We did it. Then we also used the common thing like Google Meet, GoToMeet, Zoom meeting, common relevant videos we shared with the students, and we discussed then online with videos, and we bridge the we reinforce the critical elements in the videos, like dressing, injections, things like that. Then another thing was WhatsApp's voice script, small voice script and small video discussion. We did it because that was the only feasibility for some of the students in remote area, though we had a very good LMS system and all. Some of the time we need to compromise with what is available and feasible for the students. And we also used a case scenario Google form answering for the students, especially for a health assessment, neuro check and all things like that. Then at the end, you know that the online teaching does not have that stringent strategies to do the evaluations and all. There was a chance for high inflation. So what we did is we used an Govt grading system. So that's what we did for Govt grading and grading system to keep the grades within the normal distribution. Okay, next slide, please. Okay. So this is the Moodle page. We have all the courses, e-learning services in SQ libraries. We have all the courses are available in the Moodle. So when I use my Moodle, this will be the look. The next slide, please. Okay, so this is the maternal health clinical course in 20 spring. So this is how it acts. So we have announcement, we have welcome messages, we have open discussion, we have we break the students in small groups so that not all students will be access to every single thing. Each teacher will control a group of students. Like, see, I was in charge of antenatal. So I have arranged the students in different groups. See, we have an posted abdominal examination video, NST, then we have all the discussion forums. Next slide, please. You will see how we use these things in a big blue button. Can you share the? I don't know why. Okay, so this is how it looks in the discussion forum. These are the materials we use. So this is how the big blue button. Say this is the play. I cannot. I'm sorry, I cannot play the videos and things like this. There's a constraint here. See, these are the facilities: chat facilities, webcam, audio, emoji, and multi-user web whiteboard. We can use it, and the screen share, polling. When we use poll everywhere software, when I place the slide in here and the students can do the poll everywhere, clicking also, so we will know how they are pacing with us. And then we have breakout rooms, like say research projects are there, we can make them as a breakout room, and then we can go to each room and guide them. So this is the best option we used. And big blue button is more than Zoom. So this is the facility we used most of the faculty in our university to teach during COVID-19. Next. Okay, these are the links. If anybody is interested, my limited what is it, technological competency, I used this. I made this YouTube for abdominal examination and non-stress test. And this Google Form scenario is also there in the cell. We also used PowerPoint, narrated PowerPoint videos, and our technician from his home, he made a video and he transmitted to everyone so that the teacher can get the help and all. We have an exclusive technical section for updating and for helping us, and then 2 technicians also is there. But because of this COVID-19, we were all handicapped to get any of these facilities. So there were many challenges, but there were opportunities also. So what we can say to conclude, COVID-19 has given the opportunities, and there is a strength for this one, as well as though there is a threat and weakness in this ERT mode. Let's go with this short analysis of ERT challenges. Let's go with the last slide, please. I don't know why. This is these are all the policies. And another one more thing I wanted to tell you, we did incorporated weekly student satisfaction survey and student satisfaction report, because we need to know what are their difficulties. There were 7 questions posted to them. Is the learning materials feasible and appropriate for them? Are they able to get these things? And then these reports, based on their reports, we keep changing our strategies. First of all, in the first ERT policy, they said to use the Moodle. But in the second week, we had to use the common platform also because of the inequity and connectivity in the students level and their feasibility to get the strong LMS system in their remote area. So these are the strengths, weakness, and opportunities, like advantages, disadvantages, and things like that. So what were the strengths to ERT we had? So continuation of education was the best strength we could use while using the ERT. Then it was favored digital generation, because when we teach the face-to-face education in the class also, I have seen many students are using their mobile, and when I ask them, they will say, Miss, we are looking for the current research. So they are very tech savvy, and then they will record also all our lectures and explanations so that they can hear it. While we demonstrate, they will keep recording it so that they can listen at the end. So these tech savvy students, actually they welcomed this ERT owing to a learning management system. Now most higher education centers are thinking about to install an effective learning management system. That's a strength, and then now we already have it, and we are getting updated with the current virtual technological aspects also. Technically skillful faculty. Now I myself is an example. I got really updated with many technical aspects. Off-campus e-resources. We have good library resources, but not all the resources were accessible to the students as e-resources, but university now shifted and made available almost all the resources in the central library to the students as so e-resources be making available. Then student-centered curriculum. Definitely ERT has favored the student-centered curriculum because it demands engagement, empowerment and motivation from the students. Closed loop communication. Definitely without communication, collaboration, we can't succeed in the ERT. So these were the strengths. And then what opportunities? It's creating coherent digital education strategies. Definitely. Then exploration of newer teaching platform, say like what she said, shadow health and other things. These were newer technologies, but because of its cost effectiveness, most universities or education were not able to buy and install. So now we will invest and we will do it. Then reverse mentoring to update technicals. This is the concept which I would recommend, because it's not easy to invest a very good amount of money in in updating the faculty on the spot and or also on a long run for technological aspect, because it costs. This is a cost effective. We have young, energetic, technically competent faculty, and so we can we can pair senior and junior faculty, and then the junior faculty can share their technical competency to the senior faculty, and senior faculty can share the professional competency to the junior faculty. So this reverse mentoring is the best approach I would recommend, and I myself updated with these things also. Designing online friendly courses. Now the faculty has got the confidence and courage to design new online courses, and they can earn money in in designing and providing online courses also, and the university can attract international students by designing online courses also. Establish secure communication system. Because of the insecurity or security issues, we have to establish we have taken all precautions to make a secure communication system. Ensure streamlining of evaluation process. This is another thing which I already told you, that we did not have much strategies except for Angoff method. What that webcam monitoring is another one of the strategies to reduce their plagiarisms and all. But we have to invent and modify our evaluation strategies to reduce the plagiarism and to reduce the grade inflammation, or to reflect the grade what exactly the competency of the students. Now, the weakness and threat, we already mentioned most of the things. Lack of contingency plans, because ERT is just a sudden onset and there was no contingency plan, and lack of faculty preparedness, lack of support system, work and family imbalance. This is another conflict both in students as well as in the staff, because we say that it is convenient, we don't need to dress up and we don't need to have cost effective and all, but there is a conflict unless and until we have a streamlined planning correctly, because students at any moment students can jump in and then ask questions and they keep nagging on you, and at the same time faculty with small children and they themselves are also on online teaching, and we are in another side online teaching. There is a conflict within the family also. So this imbalance is there unless you are planned and very well designed courses. There is a conflict. Non-challenging, less motivating students. Definitely we can make it, but this is when, especially when we use non-synchronous methods, this is going to be a non-challenging, less motivating, because they will go in their own pace and then they will always pass the deadline and the teacher has to keep nagging and behind them to submit the assignment and go for the activities, and so there is a challenge in that. Lack of integrated assessment system, which I already mentioned. Then threat, equitable access to students, we already mentioned that one. Pressurized to buy but gadgets, I told you that sharing the common gadgets is not convenient for an easy and appropriate education, so they are pressurized and cost effective, financial problems and all. Faculty shortage or multitasking, I told you that whenever I had a computer issue, I usually call my technician, he immediately come and do every single thing for me. Now I am handicapped, so I had to do multitasking, and then it is another thing. Then faculty shortage, it was not a concern for us. We did not have any attrition or any salary slash or cost effective cost concerns or anything, but it was a concern in many other institutions, which I came to know that. Unseen for plagiarism, definitely students are always students, their psychology is to have a good grade, so they will use any modes and methods to use to get a good grade. So teacher need to be very vigilant in very appropriately design and do the evaluation strategies and assignments. Risk of academic integrity, definitely with all these threats and weakness, you can imagine what are the risks in the academic integrity. So I hope I have shared what is our experiences and what are our viewpoints. These are my references. What are our future plans? Our future plan in university, we are academic council is thinking about web viewed examination, and then investing more in the learning management system to get more clinical virtual simulation. Strategies are being planning also. So with this one, I am concluding. I take this opportunity to thank everyone, and I'm so happy to see my classmates, my teachers, and my parent institutions also. Thank you all.
Madam, thank you, madam. We have one question in Q&A. Madam,
Yes.
From Pradibha, did you take a student's feedback regarding this online teaching? I think this question is already answered in your session. Do you have
Yes.
anything more to add, ma'am?
No, we said that weekly, it was mandatory. When you go back to my screen, you can see that weekly each teacher is posting online satisfaction survey, and we make sure that the next day before starting the next week, we get the report and we compile the report, and we will see where we need to modify, which area we need to, and we took the immediate strategy at that moment itself. We did not go for until the end. It was an ongoing and a continuous evaluation, weekly satisfaction survey, report filing, and remedial strategies.
We have no more questions in the chat box. Okay. So thank you for delivering a wonderful session on challenges in emergency remote teaching. faced by institution, faculty, and students. The areas to be addressed, like the identification of student needs, the system preparedness, and the areas to be focused by the educators and also the faculty preparedness. And also for sharing emergency.
Okay, now we will move on to the next session that will be dealt by Ms. Adriana Horn. Hi, good morning to Adriana. I know it is very early, now 5:27 at UK. Okay, still you are online. Okay, ma'am.
Good morning, everybody. As I say, yes, I'm from working in England at the moment, and I have done my nurse training in South Africa, and I've also worked in Malta and did some teaching in Malta and in South Africa, and also I've worked in a few of the African countries where we've developed different usage of all other areas. One of them was eye clinics and orthopedics, and so this has given me a very good stand for the COVID when that started, in how to act quickly, because that's what we had to do. To try and minimize all the risk to patients. If you can put up the slides for me, I'll be very happy.
Yeah. Mr. Prabhu, please share the slide.
Do you want me to share the slides, or are you going to share my slides? I'm happy for either way.
Okay. Okay, is it okay for you, Brianna?
Yeah, no, that's fine. We can go to the first one. So what was the aims? Why, for me, was one of the things that we had to ask ourselves, why, what could we do to help the population in Tower Hamlets? Because in Tower Hamlets, our population is very diverse, culture, and we have a lot, most of our population fall under BME, so they are the vulnerable group that we found in all the studies we've seen, and it was how could we help it. So we looked at to see, okay, if we can do early detection for people who is suffering from them. We wanted to prevent anybody coming into hospital who didn't need to come into hospital. And if we could do self-management at home, it was how could we keep people safe? Because that was the real intention of keeping our patients safe, our staff safe, and so the population safe. And one of those was keeping people at home. And also, so then it was, how do you do it? So you get people to self-manage. You empower them again to treat themselves. And that was one of the important things, so that they could know, yes, I know how to deal with my illness, and this is where I go. So, and for that, we had to do our diagnostics and early intervention. And that's how it came by to where we were going. On the next slide, you'll see, so then we had to set up our different criterias. So our exclusion criterias were, we didn't take children under 10. Because there is children, as we all know, can go sick so quickly that you need to see them. Patients with a DNIR in the community, that was signed in the community, we didn't take that because you have to do a consent with the patient for a specific area when you do a DNIR. if you are known to working with DNARs in the different areas. And also patients who are already in care homes, because they've got the carers with them and they can do the monitoring. So that was the patients we excluded from to be able to be in our life criteria for patients. Then it was how did we refer? So the people who could refer to us was general practitioners. That was any general practitioner. And I think if you know the English system, I don't know if you all know, but anybody who is in a resident has the right to have a GP. And no GP can refuse to register a patient. So it opens it up for everybody. So they had access to the service, and they could do it by two ways, either contacting us via email and then or sending us, calling us. Then the other referral put into us was the hospital. Discharges that the hospital did, that is our acute hospital and neighboring hospitals, and like the UTC, the urgent care center. So any of those people could refer the patients to us. Also your outpatients, although the outpatients at that stage stopped, but it was any area in the hospital. It might have been ED, it might have been from your medical wards or your surgical wards. Anybody could refer the patients to us. Then the processes that we followed is we divide a questionnaire for this hospital or the clinician to fill in. They then send it to us. On there, we got the patient's demographics, their age, and if they had any previous medical histories and any factors that we needed to take in place. We also then sent out a home testing kit to the patients. Now, in the home testing kit, it was a blood pressure machine and a saturation monitor and a temperature probe and a fact sheet that gives them all the facts around coronavirus and how to deal with it, and also a monitoring sheet for the patient to keep their own monitoring when they get all this. Then we had a delivery system that was done via persons on bicycles that would collect the kit from the hospital, and they will then take it to the patient's home. The next day, the clinicians that we had doing the monitoring will call the patient. We have a system, Accurex, that we use because it is compatible with our NHS emails, and it also records your session with the patient, and then it sends it back to you so that you can incorporate that session into the patient's notes. So that was really important for us, and it was a secure link. That's why we're using Accurex, because we don't breach any data protection rules around that. So then the clinician will set up the video. They send it to the patient have to click on the link and say, yes, I'm happy to participate in it, and then come back to you. And so then the clinicians we have will go through every detail of the patient, what they needed, how to use the kit, how to do their daily results, monitoring, and then you make an appointment with them for the next day to say, this is when we'll call you back to get all your information again. And we could also do online prescribing. If the patient needed any medication, or you think, oh, they might benefit from an antibiotic, you could do that, and the pharmacy would deliver the medication then to the patient's home, because we wanted to reduce the contact very much in the whole system. So that was one of the important bits throughout this, was trying to reduce all contacts. Then the next one was the referral. Every day when we phoned the patients, it was done in the patient's notes. And then we will send a letter back to the GP to say we've spoke to them and this is how they are progressing. Or we would call the GP and have a word with the GP if there was anything. If we were worried about the patient because they didn't answer, or you just couldn't get hold of them for 2 days or a day, or you could hear over the phone you were worried about them. And a lot of patients that we found was very anxious to come into hospital. Either they had friends or family passed away because of COVID, or just the publicity around COVID. There was quite a lot of panic amongst these people who got sick and who didn't want to come to hospital. So and they didn't especially wanted to go to our emergency departments. So we could bring them into the UTC, where they don't go through the ED, so that also reduced the risk, and they would see a clinician straight away in the UTC. So we reduced their exposure from other people, but also them exposing themselves to the rest of the public. We did the urgent care treatment referrals that we have done. And then we've sent out the police. If we couldn't get anybody from the patient, either family member or because we found one or twice they spoke to the doctors already that day, and sometimes the people just didn't want to talk to us anymore. We had a few, as we know, you've got all different patients. That sometimes they just don't want to speak to you. Some of our other patients absolutely loved it, because that was sometimes the only interaction they had with another human being. Even though it was on the phone and not face to face. And that was one of the important things. So we didn't just treat the patient, the physical patient, but also we treated the psychological aspect of it, because we could put their mind to rest and they know they were looked after very well. And we also had access to the mental health crisis line if any of our patients needed to go to the crisis line and or they needed more support. They could phone and we could give it to them and we could refer them to all of that. Then I think that one of the most important things was our clinicians were really well, it is very well trained clinicians, and most of them have, is very empathetic with the patients, and they built up a rapport with the patients, because we only had a very small number of clinicians doing the service, because we didn't know exactly. It wasn't a tried and tested service. It was a service we stood up within 24 hours. And we were still feeling our way through it. If we go to the data sheet, you'll see we've done we've done quite a few patients. It's close to, I think, 2,000 patients we've done throughout the COVID. Oh, the number of patients was 300. The length of stay was about 10 days. Now that is very, very good. That when we set out for the program, that was basically what we thought we might need to monitor the patients, because we saw at the 7th day, the patients either got better or they got worse, and then you had to bring them into hospital for further tests and to make sure if they needed antibiotics, we could give them the antibiotics. We completed, I'm not going to go through everything what happened to the patients. As you can see below, this is what we've done with the patients. You know, all of them got different areas and they went to different, needed different feedback. And some of them got better and we then discharged them. Quite a few of them, you can see there that we had to do 2 angiograms. With this, we also, and if you remember, I talked about the care homes wasn't included in the study. Now you might ask why. We went into the care homes and did weekly testing on for coronavirus in the care homes, both with the staff and with the residents, so that we could contain the outbreak in the care homes, where also your most vulnerable people are, and they weren't, you couldn't just isolate them like you could do with some of the patients in their homes and put that in place for all of them. Our service, I think, was very well liked. It was the first in London that did the home monitoring service. So quite a few of our other boroughs then started to also adopt this method to do early detection of the patients. And yeah, that's me. And I don't know if people have any questions, then please feel free to ask.
If anybody has any questions, you can ask now.
Okay, we will. Okay, thank you, Ms. Rihanna, for a wonderful presentation on home monitoring. So we are also doing home monitoring, not the way you are doing there. We are doing, and now we are moving more elaborately on home monitoring, because the COVID cases are increasing day by day. So thank you for us with this session. Thank you so much.
So how do you do home monitoring, if I may ask? Because I always think it's, we can learn from one another, and you know, and to see, because it's all, everybody do it differently. And I always think there's not just one way to do something, because you might think of something differently because you've got different constraints, where with us we might have other constraints that you don't have. So we're always open for learning, and that helps us.
Yeah, towards the end, we will share some of the experience of our home monitoring.
Okay, thank you.
Mrs. Celine Scaria from UK has joined us for the final session of this international webinar series. Mrs. Celine Scaria qualified BSc Honours in Nursing from Jamia Hamdard University, Delhi. She worked as nursing tutor and tutor for community geriatric animators in Ministry of Social Justice and Empowerment, New Delhi. She migrated to UK in 2004 and started her career there as senior registered nurse in Bard's Health NHS Trust. She was a trainer for person-centered approach in caring patients with dementia. She held positions like ward manager and manager for clinical observations in emergency departments. She took her MSc in advanced nursing practice at City University London and currently serving as advanced nurse practitioner at North East London Foundation Trust and Royal London Hospital Urgent Treatment Centre. Mrs. Celine's career has been part of COVID-19 home monitoring team in her hospital since April 2020. Madam will speak on clinical streaming in emergency departments. May I invite Mrs. Celine's career to share her thoughts on clinical streaming in emergency departments.
Thank you very much. Unfortunately, I'm not one of the Kottayam Medical College product, unlike everybody else who have all been talking about. Anyway, but I always keep an eye on what's happening back home in Kerala, and it's very close to me. So I watch the news every day. And there are certain concerns which I thought I should just kind of rectify it over there, because with the current practice which is happening, this closing down and everything. In UK, we suffered a lot with the COVID-19 because we lost so many lives, because the initial thought was to keep people at home and away from the hospital, and people were just scared. It's the same way like back home people are scared. So after the initial hiccups, we started kind of getting a streaming guideline for patients where they can be safely treated, because with the COVID, people were only concentrating on the COVID-19, forgetting about the other health reasons why people are being admitted to the hospital, like cardiac patients, diabetic patients, other chronic illness patients. They were not being treated at that time. So because we just wanted to prevent the COVID-19 deaths. So now the situation has come to this way that the COVID-19 is getting reduced, but the other kind of illnesses are emerging. So we wanted to keep a safe service for people to come to the hospital. And in UK, we have different types of services. Can I have the next slide, please? Thank you. Any patient or any person who has got any problem, they can call a helpline, which is 111, where they will have been able to talk to a clinician, and if they can be managed at home, which they will do, and if it can't get managed, then they will either refer them to their own general practitioner, or they can get into urgent treatment center or other aspect of care instead of coming to hospital. And otherwise, if it is a life-threatening situation, they have to call the 999 emergency line, where there are qualified practitioners going to assess the patient in their home, and they will be dealt over there. Either they will be brought to the hospital or they will be treated at home if they don't want, because mostly at this COVID-19 time, it's more of panic and anxiety attacks, which is causing like cardiac problems, like cardiac attack or heart attack kind of symptoms. So they get treated over there. They have their ECG and all the other treatments, and they stay home safe. Or the patient, the next one is the patient can call their own general practitioner, where they will be treated either telephonically. Most of the general practice at the moment are doing remote consultations. And if they come to the emergency department, they can either be gone to the satellite hubs, which is same as telephonic, plus they see the patient, they see face-to-face consultation as well. And it is called either hot or cold hubs. Hot hub is for patients who has got symptoms of COVID-19 or similar symptoms, so that the staffs are protected and the patients has got the time slots to go in there. And the cold hubs is for the other kind of patients. And when they come to the emergency department, on the reception, there is people, security there with a mask and everything. And because mask is not mandatory for everybody to wear all the time in here in UK. It's only if you are in the hospital or if you are in a crowded place, public transport or supermarkets. That's the main areas where people have to wear masks. And children under the age of 11 are exempted, and chronic asthma and all those, they're like, it's not a blanket rule for everybody to be wearing masks in the UK. You have, if you got chronic respiratory conditions, then you don't have to, you'll be exempted from that. And when they come to the hospital, there is either a volunteer or a nurse or the healthcare assistant who will be asking the relevant questions, whether they have any symptoms of COVID-19 or they don't have any symptoms. So according to that, they have been streamed. And when they come to the streamer's desk, they don't have to go to the emergency department for every single thing. If they have got a pregnancy and if it is pregnancy related, any problem, they can be referred to the early pregnancy assessment unit. And if it is a minor problem, then they can be referred to the urgent treatment center where they can be treated, or they can be referred to the dermatology or specialty clinics by the streamer, or even sometimes the psychiatric department. If it is not a active suicidal thoughts, then they have to be monitored within the hospital. And so after, and sometimes the patient can phone their pharmacy as well with the symptoms, because there are actually technicians there who can prescribe. So the next slide is mainly the streaming. So when they come to the reception or when they come to the streamer's desk, oh, sorry, it's not even that. Before that, they have been chosen to different streaming guidelines. So the first one is confirmed positive cases with or with the symptoms, patient go to red zone. It has got individual cubicles in there so that it's not they are not spreading the infection to anybody. And they have, like, even if it is not a positive COVID, they don't get the symptoms from somebody else. And confirmed negative cases without any symptoms will go to the COVID blue zone, which is the safest of all at the moment on the streaming side. Then unsure patients without any symptoms will go to the amber zone. And all these areas, we have social distancing. We don't allow, apart from the patients, nobody else can come in apart from, unless the patient has cognitive impairment or the patient is a minor. So even if it is a language barrier, we use the language line to speak to the patient, not, we don't encourage family or anybody to come in with the person. Then within the hospital, once they have been seen, there is three kind of, next slide, please, sorry. They have three kind of zones for treatment. The blue zone is for areas treating with patients with COVID-19. It could be any ward, respiratory ward, medical ward, any ward. It's all, they are specifically for COVID patients. And most of the hospital has got cold, it's cold or hot resource as well in A&E, because it's been divided into two. And ITU has got two different ITUs as well. If the person needs intubation, and if the person is a COVID positive or is symptomatic, they go to the hot ICU. And amber zone is the areas where patients with unknown COVID-19 status. So they stay in that area until they get the result out, because they get swabbed before the admission. And then they go, if they are negative, they go to the green zone, which is mainly for the elective surgeries or anything like that, because of the patient who needs admission. But if it is an emergency surgery, then everybody treats them as, what do you call, suspicious one. So the staff will be kind of putting the whole PPE kit with them. The next one is the facilities available for testing. The government initiative testing is drive-through and home testing, where drive-through is that you can log into the government website, book your slot, and they will give you the time slot instead of going and not social distancing or making a scene there. So they go and they have to stay in their car. They get swabbed. Everybody, one person will bring in the swab. You have to have your mask on. They'll guide you how to use the swab. And then you go home, you get a text message or an email within the first 48 hours. The next one, if you can't drive or if you are single or if you are staying at home, you can always ask for a home testing kit, which the same again with the government website, you will get a home testing kit via your post box. And after you take the swab, you can either post it back or you can ask for a courier to come and pick it up. And they have the means to come and pick it up, and your result will come within the next 5 days. And the hospital, the COVID swabbing is only for inpatients who, if you are going to be admitted in the hospital, then you get a swab done. And care homes, as Rihanna has already said, initially it was once a week. I think the policy has changed now. Once in every 2 weeks for residents and once a week for staff. And the staff gets an antibody testing as well. The next slide, please. The next is for COVID-19 shielding patients. The shielding, initially it was like a blanket shielding, the same like back home, you all stay indoors, and especially with people who are above the age of 60. It wasn't that bad in here anyway, to be honest. But at the moment, they have made it into risk criteria, high risk and moderate risk. The high risk ones are the solid organ transplant patients, or patients with specific cancers with active chemotherapy, radiotherapy, leukemia, or if the person has got a severe respiratory condition like cystic fibrosis, or any inborn error mechanism, metabolism disorder like homozygous sickle cell, or immunosuppressive therapies if the patient is, because with immunosuppression, they are at high risk of infection. And women who are pregnant with significant heart disease or congenital or acquired. Then you got the moderate risk, which many of them aged 70 or older, regardless of medical conditions, under 70 with underlying health condition and or chronic COPD, respiratory disease, emphysema, kidney disease, heart disease, diabetes, chronic liver disease, neurological conditions like Parkinson's, and with children with disability, if you have had respiratory symptoms, like if you have had treatment 4 times within the year for respiratory infection, then you come under high risk. Anything less than 4, then you come under lower risk. And people who are overweight, just like me, and those who are pregnant, they are on medium risk. And after the pregnancy, it's after 28 weeks, they go to the high risk. So if the COVID-19 shielding patients, the high risk one, if they have to call 111 if they want to come to the hospital. So when they call the 111, 111 will then contact the hospital. If the patient requires emergency admission, then they go directly to emergency department where they will get a single room. Then after initial assessment and everything, they will be fast-tracked to the admission unit instead of staying there. And if it is for any other process like UTC or anywhere else, they get a slot allocated time where they have to be seen immediately within that time. Then when it comes to, next slide, please. Injuries. We used to treat injuries within the ED department. Nowadays, the minor injuries or limb injuries goes to the minor injuries unit, where if they haven't got any COVID-19 symptoms, they have COVID-19 symptoms, they go to the emergency department. And once they have been seen by the minor injuries unit, and if there is a fracture, they get referred to the fracture clinic from there after initial management. Then the fracture clinic either do online telephonic consultation, or if they need a face-to-face review, then they call them in with the same time slot to see them. Any patient with over 65 with fracture hip injuries, which is classified as orthogeriatrics, they go to us immediate, they need immediate assessment and management, because with orthogeriatric patients, the earlier the intervention, the better chance for them to be walking again. They have to be operated within the first 48 hours, then they have to be ambulatory, and they should be discharged within 2 weeks with intensive physio, and the rest of the community facilities available for them, like occupational therapist, physio, home health, and all the patient has to be screened for COVID prior to surgery, and all electives. All elective surgery goes to the green zone of the hospital. And next one is the aftercare, because once they get discharged, most of the people has been having problems with anxiety, panic attack and everything. Once they get discharged, they either get referred to the remote home monitoring service, or they get discharged, they get referred to the remote home monitoring service on discharge, or from the consultation, after initial consultation from the GP. And there are COVID-19 clinics in the hospital, which is run under the respiratory specialist. Then they get regular consultations by the GPs, and even the respiratory specialist, if they want, they have repeat X-rays various times to check the progression of the disease or how the lungs is getting better. Then they have crisis line and counseling services, which even patients and staff can access. And then you have number, all the staff has got the number for that, and all the trust has got the facility for the counseling for the staff. And physiotherapy can be respiratory physiotherapy, or with a long-term stay in the hospital, they can have other physiotherapy, which is for the other stuff. So that's all about what we do in the hospital. Thank you very much. Any questions?
Thank you, madam. Madam has given a detailed description of the types of services, COVID streaming to different zones, facilities for testing available for patients and staff, and a COVID shielding. Thank you, madam. If the participants have any questions, they can ask now. No questions are seen in the chat box.
Thank you for that.
So now we will move, if there are questions, we will move on to the discussion session. We have all the speakers online, and we have received some questions in the Q&A. And first question is from Lena to Dr. Anna George. Madam, the question is, are the platforms for digital experience like Canvas, Shadow Health, etc. are free of cost, or they are paid?
Good question. So the Canvas is a platform that Molloy College uses. So that is free for all students who are enrolled. Shadow Health is costly. And so we do make the students pay on their first year of admission, and they can use that system throughout the 4 years. So each student, we make them pay $200 to buy the Shadow Health for their clinical experience, and they keep it, and each year we build up on the experience that they get and newer scenarios and case studies. So they have it for 4 years to use.
And we have one more question to you from Dr. Sissy Jose. While having web camera controlled examinations, how would you manage power supply failure or connectivity problems for one or more students?
So I have to tell you that I have not come across in United States. We don't really have power failures as much. So that is really not a concern. Having said that, yesterday we had a big storm, and I guess when many don't have powers. So what I told my students, you can unlock the quiz. If it's an exam, you can lock it after every student took it, and then you can lock it for just one particular student. If for some reason she was not able to take the quiz, you have the ability to unlock it for that particular student. Yes, we have that ability to do.
Thank you for answering these questions, madam. Next question is addressed to Mrs. Lena Alapat. This question is from Anju, and she is asking about the immunization of COVID positive neonates.
So the newborns that we take care of, they all get hepatitis B vaccine within 12 hours if they're over 2 kilos after birth. And even though they are positive, we are giving them the immunizations. And the 2-month vaccinations are actually after discharge from the newborn nursery or the NICU. And we are hoping that the babies are healthy and they will be definitely receiving all the immunizations. And we do encourage all the immunizations.
Thank you, madam. We have one more question to Dr. Anna George. This is from Dr. Usha VK, Principal, Government College of Nursing. She's asking, under learning management system, how the students can get across to virtual patient during lockdown?
Through the learning management system, I showed you that we have that Zoom. In that Zoom, we, like I showed you in the PowerPoint, we tell them to do like a scenario while you are there. You give a scenario to the patient, say, and we tell them to have a family member with them while they're examining and you're watching. I don't know if I'm making myself clear, but I wonder if that's the question that she had. How do you virtually examine a patient? I'm hoping I answered it correctly. Usha ma'am, if that's not the answer, if you could ask the question again and I could reword it. But this is how we do it in Zoom. We tell them to examine the patient while we are actually seeing them, and we have a grading criteria on when they examine the patient.
Thank you, ma'am. Then next question is addressed to Dr. Girija. It is from Shahina. She's asking which are the most reachable portals for digital experience.
You're muted.
Madam, please unmute yourself. Madam, we cannot hear you. Please unmute yourself.
Okay. Question one more time, please.
The most reachable portals for remote teaching, emergency remote teaching.
Okay. In our system, we used our own system of Moodle only. That was the accessible and available for all the students and the faculty. So we did not have any problem except for first week in the big blue button because of the connectivity and the equity in the what strategy we used to overcome that. The university has collaborated with the online internet agency, and they have given the subsidy to the students and made sure that they got the connectivity to all students.
Thank you, ma'am, for answering the question. If any of the participants have any questions, you are free to ask now. Just raise your hand. We will unmute them, and they can ask questions directly to the speakers. I think there are no questions. So we'll move on to a discussion on home monitoring services in Kerala, and that will be done by Amrita. Praful, please unmute Amrita.
Amrita, can you hear?
Amrita, are you with us?
Praful, please unmute Amrita.
Hello.
Hello. Could you unmute Amrita Vinod?
Please unmute Amrita Vinod for sharing home monitoring services in Kerala.
Hello, ma'am. I'm Amrita Vinod, second year MSc nursing student. So as a part of a community of nursing posting, we have posting in PHCs, in both PHC, that is Adarampura and Etumanur in Kottayam. And we had posting in public health nursing department. And there are two PHCs, that is Etumanu PHC and Adrambura PHC. Etumanu PHC is under DME and Adrambura PHC is under DHS. And in the public health department, we are working along with the public health department staff. The activities we have done are, we are collecting the details of coronary patients through the grassroots level workers, like ASHA workers. Then we are doing a continuous monitoring and surveillance of the patients. Then we are conducting antigen test in, we are conducted in Etumanu municipality, that is in bus stand, and also in Etumanu fish market. And we have conducted mass awareness campaign through posters and propaganda. Then we have during the breakdown period, we have participated in the program named Dr. Home, and in that we are going to the homes along with the doctors and other staff such as lab technicians and pharmacists, and we are monitoring the patient and providing medicines. And also we are conducting a project that is on knowledge, attitude and practice regarding the prevention of COVID-19 among patients on quarantine. It is a comparison study between home quarantine patients and institutional quarantine patients. So now we are conducting the study. And also we are providing a hand washing technique, that is health education on proper hand washing technique, thereby supporting the breakdown chain. So that's all regarding our activities. Thank you.
Sharing about the home monitoring services in Kerala. We have one more question in Q&A. It is, Madam, can you suggest the best platform for teaching? I think Dr. Girija can answer this question.
Please unmute, Girija.
Madam, please unmute.
Thank you. This depends on many other factors. What is the orientation level and availability of the both synchronous and asynchronous methods available to that territory, that institution, that group of people? Because for us, what is my accessibility in this learning management system, Moodle was the recommended ERT policy, and because it has got an accountability and it shows the students logging in, and we have the records of students' activities, and it keeps the integrity of the academic integrity and security of the institutional learning management system usage. But I cannot recommend this because not all institution is having the privilege of this strong learning management system. What is ERT says? ERT says use the basic available mode which is accessible to that population. This is what I can recommend at this moment. Hope I answered to you.
Thank you, Madam. Thank you, Madam. Are there any more questions? We have not received any questions in the chat box, and there are no more questions in the Q&A. So I think we can wind up the discussion. Now I invite.
Can I just add one point here?
Yes, sir. Yes, sir. Definitely. Yes, sir.
Yeah, this is regarding the home-based care in the country. The Ministry of Health and Family Welfare, Government of India, has started a e-Sanjeevani telemedicine online OPD facility, which applies in all the states. But in Kerala, we have this OPD facility free of cost so that you reduce the crowd in the hospital. The number says around 125 appointments per day, which is the highest in the country, it seems. There is an online facility, especially people with diabetes, hypertension and all that. They can get an appointment and they will be prescribed various medicines as needed. So esanjeevani.in is the website. So people log into that and get help from the doctors. So that is one more facility provided by the government in the country and especially in the state to help them in the home-based care. Just wanted to add along with all the other inputs. Thank you.
Thank you, sir. Now I invite Sister Consolator to speak a few words.
Hello, Sister Consolator. Sister.
Hello.
Sister. രണ്ടു വാക്ക് സംസാരിക്കോ?
എന്നോടാണോ? എനിക്കിവിടെ ഒന്നും കേൾക്കുന്നില്ല മോളെ.
കേൾക്കുന്നില്ലേ? അയ്യോ.
കേൾക്കുന്നില്ല. ഇച്ചിരി ഫെയിന്റ് ആയിട്ട് കേൾക്കുന്നുള്ളൂ.
ആണോ?
I sent a note to you.
I think she can speak. You all can hear clearly.
അങ്ങക്ക് കേൾക്കാം. സിസ്റ്റർ പറഞ്ഞോ?
കേൾക്കാവോ? ശരി. All the speeches were very good. My congratulations and thanks to all of them. So all the speakers. So I was very happy to see my former students all in good position, doing well. I am also keeping well. Thanks for giving me the chance to attend this webinar. So once again, thanks to all. That's enough.
Thank you.
എനിക്കൊട്ടും കേൾക്കാൻ പറ്റുന്നില്ല. ഇവിടുത്തെ എന്റെ മൊബൈലിന്റെ കുഴപ്പമാണ് ഞാൻ അറിഞ്ഞൂടാ.
ഞങ്ങൾക്ക് കേൾക്കാം. Thank you, sister.
Let me remind the participants.
What?
Hello, sister. എന്തെങ്കിലും പറയുന്നുണ്ടോ?
I remember all of you. Girija, Anna Sebastian, then who else? Lena, all these people. So once again, congratulations and thanks to all of you.
Thank you.
Once again, I remind the participants that link for feedback form is open in the chat box. You may fill out the form. Only then you will be receiving the certificates. And I think there are no more questions to discuss, so we'll wind up the session. So nurses are the key members of healthcare team charged to control and prevent the spread of infectious diseases. Moreover, nurses are on the front line providing direct care to the individuals infected with COVID-19. Nurses' sense of duty, dedication to patient care, personal sacrifices, and professional collegiality are heightened during this pandemic. These 2 days, we have discussed the challenges of COVID-19 on disability management and nursing education and practice. Now we have come to the end. We had participants from different parts of the world. Thank you for the active and enthusiastic participation and interaction, which made the series a grand success. We will be failing in duty if we do not add a note of thanks to everyone. May I call upon Mr. Lena A.T., Associate Professor, to propose word of thanks.
Okay, good afternoon to all and good night for some of the panelists. Respected Principal Ushama, panelists, dear friends and attendees from different countries. So today is the last day of our webinar series on challenges of COVID-19 on nursing education and disability management. So the coronavirus outbreak, which originated in Wuhan, China in late December 2019 and spread across the world, creating a COVID-19 pandemic in less than 3 months. So as on date, on today, there are about 1.8 crore deaths and made 1.8 crore cases and 7.1 lakh deaths by coronavirus. So it affected almost all the areas of our marketing as well as education, then development areas. Every field has been affected by coronavirus. So as educationists, we are more concerned about the education of our students. So we have moved on from our traditional teaching to online teaching and remote teaching for our students to impart our knowledge. So I think this type of webinar will enhance or equip the educators to deal with the new technologies to educate our coming students in dealing with the present scenario. Okay, so let me go into my duty. So first of all, let me express my sincere gratitude to Dr. Usha Vike, Principal, College of Nursing, Kottayam, for her support, enthusiasm, which helped us to plan this webinar series. Thank you, ma'am. Next, I extend my sincere gratitude to Dr. Varsama Joseph, former principal, who delivered the keynote address and inaugurated this session on the first day. On behalf of Government College of Nursing, Kottayam, I take this opportunity to express our thanks to you, ma'am. Sister Consolata is also a former principal and our teacher who showed always express her sincere love and gratitude to our students and our institution. And she participated in these 2 days webinar series. So from the bottom of my heart, I express my sincere thanks to Sister Consolata. Next resource persons on day 1, Dr. P.T. Baburaj, Mr. John George, who also joined today also, Dr. Hannah, Mr. Rajesh Divagaran from Geneva, all participated on first day webinar series. So our sincere thanks to all the resource persons. Then resource person on day 2, Dr. Anna George, Ms. Lena Alapat, they are from USA, Dr. Girija from Muscat, and Ms. Rihanna and Ms. Celine from UK. So I think during their off time, or they are in different time zone, they took part in this webinar. So thank you so much for all the panelists. Then Ms. Rihanna and Ms. Celine, I think they are in the early morning and they are busy with their clinical schedule and all, since they have participated in this webinar with so much enthusiasm. So sincere gratitude to both of you. Then attendees. So without you, this webinar series will not become an effective one. So for these 2 days, we have about 360 attendees registered for this webinar. And we had attendees from US, Gulf countries, and different parts of India. So we express our gratefulness to all the attendees. Then technical support. In order to plan and conduct a webinar in an online platform, need technical expertness. So in this venture, Mr. Praful Sanjeev, who is an exemplary in the field of computer science, had done a great job. So without his support, it will not become a success. So I hereby acknowledge our gratitude to you, Mr. Praful Sanjeev. So I am also expressing my sincere gratitude to the first year MSc graduate who shared her experience with the home monitoring, Mrs. Anjana for giving the technical support, and Ms. Raki Manjuran for organizing this webinar. So I am extending sincere gratitude all the panelists, all the attendees, and all the well-wishers who participated in this webinar series. Thank you all. Self-applauding also. Okay, now the attendees can leave the webinar
after filling out the feedback form.
Yeah. Okay.
Those who find any difficulty in filling out the feedback form, just inform us. We'll be sharing the feedback link through mail. Thank you, everyone.
Anna, you are muted. Are you speaking? It's Anna Jo.
Sorry. I wanted to tell you that it was such a well-organized conference. I really enjoyed it the first day and today. Hats off to all of you. You all did a wonderful job in organizing it and doing it so well.
Thank you so much.
You're welcome.
Lena, please unmute. Lena.
Can you please send me the evaluation link again? Because I don't seem to find it. Is it on the
either? Not fill, only for attendees. Okay.
Oh, it's not for us.
So Suleika, I would like a certificate though.
Of course, we will send you.
I'm so happy to see Sister Consolata.
I think she has. Hi, Sulega, I think.
Sulega.
Yeah.
Yes. Congratulations, great attempts, innovative methods. You have updated yourself also. Technology. It's a challenge made an opportunity for you too. Thank you. Thank you, dear. And I am so happy to see you all and our Consolata ma'am also. It was a great privilege to be with us.
Oh my God. Yeah.
Thank
So
you.
happy to
Keep-
see you,
keep
Kirja.
in touch.
Because I
Okay.
requested her to-
Bye bye.
So she was very happy to join, and her willingness is
again.
Listen, she remembers everybody's names. Even she remembers
Huh?
the maiden
She's
name.
wonderful still now.
Sebastian, yeah, she remembers it all.
Wow.
Plus.
She's very compassionate teacher still, you know, very caring.
I still
And
remember
role-
she's very strict though.
I know. Role